Alright folks, it's time for yet another video discussion in this series on clinical toxicology. The subject this time is techniques to prevent gastrointestinal absorption, corresponding to Chapter 5 in Goldfrank's Toxicologic Emergencies. Note, I'm going to be using the term GI decontamination pretty much as an equivalent term for the title of this chapter, and we'll also see that a substantial portion of this chapter is covered in other videos I've created or curated for this series about specific GI decontamination methods, so I'll be directing you to watch those other videos rather than just repeat everything again here. The learning objectives for this session are that you'll be able to make a more or less complete listing of the potential GI decontamination methods available to employ after toxic ingestions, and to be able to identify which conditions might support the use of one method of GI decon over others. Much of this textbook chapter lists and summarizes multiple studies conducted to determine which GI decontamination methods work, under what conditions they might work, and or which might be better than the others. But to give an overall summary of all of this data, there's a lot of controversy but little rigorous evidence regarding the value of GI decontamination. There are methods that empty the stomach, such as inducing emesis or gastric lavage, and there are methods that allow the toxin to remain in the GI tract but to prevent its systemic absorption, such as administration of activated charcoal, or by speeding the passage through the GI tract, reducing the time available for absorption, through the use of cathartic agents or by whole bowel irrigation. The chapter authors sum up the main idea in this quote: "The efficacy of techniques used to prevent absorption of xenobiotics depend on one simple concept. At the time of the intervention, there must be enough xenobiotic in the GI tract to alter the patient's outcome if absorbed. In reality, this is almost never known." But how often is it that GI decontamination is really going to make a difference, where incomplete and not exactly predictable changes in the amount of drug ultimately absorbed are going to result in a good clinical outcome, when not doing so would have resulted in a bad outcome? And we might also apply the same question to all poison patients and all toxicology treatment options. I want to point out that this slide is based on my own experience and opinion, and is not something I'm quoting or paraphrasing from the Goldfrank textbook. The toxicity severity range where acute medical interventions, such as GI decontamination, save tox patients is probably quite limited. If we made a histogram of tox patients, with degree of severity increasing from left to right, and the height of the graph representing number of patients, we see a major skew in the curve where most of the patients are on the less severely poisoned side, and they're likely to survive and recover, if indeed they ever got sick, pretty much no matter what we do. And there are a minority of tox patients who are so sick they're likely to die regardless. Surely we will do what we can, but not every patient is salvageable, even if we do everything right for them. But there is some range of useful intervention in between these extremes, where the patients are sick enough that they need us to make good treatment decisions, but not so sick that those treatments, those fingers we're placing on the scale, won't help. But since there are many more patients below this range of useful intervention, do we really want to subject them to potential complications when it's not going to make a difference? This is a nice thought experiment, but it's unclear where these transition points occur, and undoubtedly they depend on many factors. As I mentioned already, if there's already a subtopic specific video, I'm not going to repeat it all here, so go watch my other video about Ipecac for GI decontamination. Spoiler alert, we don't use it anymore. Orogastric lavage, sometimes called stomach pumping, used to be standard care for overdose patients in the emergency department. When I was a resident in the mid-1990s, it was losing its preeminence. I did it a handful of times as a resident, but never since the year 2000. The figure here shows an ideal situation for orogastric lavage. The patient is on their left side and with the head of the gurney lower than the feet to reduce the chance of aspiration, as fluid is introduced into the stomach through a large bore Ewald tube and then sucked out. The process being repeated to remove the stomach contents until the effluent is clear, or as clear as we can get it. Now, I didn't make my own video about gastric lavage because I found a very good one on YouTube made by another toxicologist. If you're taking my clinical toxicology course, a more convenient video link is being provided to you. And if you've just found my material on YouTube, there should be a link in the doobly-doo, the video description below. And then you should watch my other video about activated charcoal, which remains a popular method of GI decontamination today in late 2023, early 2024. There's a slightly modified version of using activated charcoal, which is to give multiple doses of charcoal. As with virtually all of the GI decon methods, it's not been clearly demonstrated for which drugs and which situations that multi-dose activated charcoal is indicated. But it may be more helpful with drugs that have enterohepatic circulation. These are drugs that are excreted into the bile by the liver, and then later get reabsorbed into the portal venous circulation, go back to the liver, and make the trip all over again. The continuing presence of activated charcoal in the gut lumen will trap the drug there, so the patient will then poop it out, preventing the drug from continuing to be recirculated, increasing its elimination and lowering systemic drug levels more quickly. There are also some drugs for which multi-dose activated charcoal could work as gut dialysis. If the drug freely crosses the gut mucosa, it can be trapped in the GI lumen, adsorbed to charcoal, so we're using the gut as a sink for the drug to increase its elimination in the feces. Strictly speaking, then, multi-dose activated charcoal for these indications is more to promote elimination than a technique to prevent GI absorption. And next, you should also watch my other video about whole bowel irrigation. And now we're back to a slide we've seen before, but this time I'm expressing my own opinion rather than quoting or paraphrasing the Goldfrank chapter. We've discussed in these videos several techniques for reducing or preventing GI absorption. And while these techniques exist, some of them are rarely used anymore, like inducing emesis and orogastric lavage, while cathartics are just no longer recommended. Whole bowel irrigation is used, but it is limited to selected cases. See that video. And what we've got left is activated charcoal. Even if it's not a panacea, there are fewer side effects and dangers associated with activated charcoal compared to the other methods, as long as charcoal aspiration can be avoided. And the current state of the art is that activated charcoal is now the most common method of GI decontamination, if any GI decon is done at all. Okay then, I'm done talking about GI decontamination for now. Go watch those other related videos about individual techniques if you haven't already, and I'll be seeing you around.